Some people don't realize that we have 23 acres right here in Long Meadow. We have a variety of services, right? A whole family of services. The Levitt Family Jewish Home, which is 24-hour skilled nursing, including long-term care, short-term rehabilitation with secure neighborhoods for our curious exit-seeking residents. We've got our Sawson Center. You can see the picture. If you haven't toured it, I'd welcome you to come tour the location because it is absolutely beautiful. You can see right there. You've got the dining room table that these three folks are sitting at, and then the kitchen behind. It looks like you or I could live there. It's a beautiful residential type setting. It's the first greenhouse model of care in Western Mass, features 2 greenhouses, all private rooms, all private bathrooms. It's consistent care teams, which is really important, all in a home-like setting. Wernick Adult Day Health, right? Your loved ones safe and cared for, dynamic setting promoting social interaction and stimulation while whether you're going to work or you just have to run errands. You don't have to worry about your loved one. Spectrum Home Health and Hospice, as well as palliative care, quality care that comes to you in your own home, right? Or we could actually have it here on the campus, whether it's at the nursing home or at the assisted living, or even at our independent living, with personalized plans for each patient. And then Genesis House, of course, our senior independent living with efficiency and 1-bedroom apartments located on the JGS Life Care campus with access to our family of services for that continuum of care, right? So it's like a CCRC almost, that, retirement community, continuum care retirement community without that hefty buy-in, which makes it really nice. And then, of course, last but not least is Ruth's House, set back away from the hustle and bustle from the main street. Very private wooded backdrop lies, of course, our gorgeous Ruth's House, but I'm going to let Christina do a tour because she's, I think, got that set up. So I'm going to stop sharing my screen and Christina can share hers.
Perfect, thank you. I have a video. It's about a little less than 3 minutes. We're going to take a listen.
Surrounded by lovely landscape grounds and private walkways, Ruth's House, assisted living in Long Meadow, Mass, is part of the 23-acre comprehensive campus of care at JGS Life Care, guided by Jewish values, serving all faiths. Ruth's House is a beautiful, home-like residence for seniors of all faiths who value their independence but may need assistance with day-to-day living activities. If your loved one is transitioning to a new lifestyle or needs extra care they can't receive where they live now, we'll make them feel right at home. Ruth's House offers 64 spacious, newly renovated apartments that residents can decorate and personalize. Residents can enjoy private or companion suites. Our residents enjoy 3 kosher meals daily, kosher snacks available throughout the day, and our country kitchen. Ruth's House features inviting dining and social areas inside and out. Other amenities include linen and laundry services and transportation to events and outings. All of this comes together to create a warm and inviting atmosphere that helps promote a strong sense of community for both residents and staff. Residents appreciate social and cultural events, including day trips to area restaurants, events, and attractions. Our memory care outings are specially designed for the enjoyment of our memory care residents. We also offer multi-denominational religious programming and spiritual support, including a rabbi on site. We believe independence is important, and our residents remain in charge of their own schedules. However, they can rest assured knowing our highly trained team is available 24 hours a day, 7 days a week to provide individualized care and assistance if needed. On-site nurses provide wellness programs and medication reminders. Primary care physician services are available on site, and a licensed nutritionist is available to discuss your dietary needs. The Garden neighborhood is a memory care secure neighborhood that has been designed to support the needs and perhaps more importantly the successes of each resident with early to mid-stage memory impairments and other dementia-related diseases. Our staff has come to know each of our residents on a very personal level and strives to accentuate skills and strengths that residents retain and not focus on losses. Daily activities are designed to create experience of success and reduce anxiety in a safe and secure environment. Assisted living at Ruth's house gives your loved one the care and support they need while allowing them to lead full and independent lives.
Perfect. So thanks for
Great.
watching that video. I know easier to play a video and make sure I don't miss anything. A lot of information. So now I have the honor of introducing Dr. May AWKAL. She has been doing primary care in assisted living facilities for over 11 years. Currently, she practices in Western Massachusetts and is looking to expand care into Connecticut. She receives her Bachelor's of Science in Biochemistry. Biochemistry from Simmons College in Boston, and received her doctorate of medicine from the University of Connecticut School of Medicine in 2009. We are proud to have Dr. AWKAL at Ruth's house as an option for our on-site primary care, and our residents have nothing but great things to say about her. Everyone I meet, the families, all of our residents, they really, she's just such a bright ball of energy and always a smile on her face. So we really love having her here. So without further ado, Dr. AWKAL, the floor is yours.
Thank you. Thank you. I just want to thank you all for coordinating this, and thank you for those who are here to listen, to learn about fall risk prevention, which is one of kind of the biggest things that I face, as well as my PAs and my providers. Just to give you a brief background, my interest in medicine started when my grandmother developed vascular dementia, and I wanted to be able to be a pioneer on figuring out a way to prevent, complications and navigating through the healthcare system. So it's really my dream to be able to do what we do and really to aid seniors and their families on aging gracefully. So fall risk prevention. So one of the biggest issues that we see with fall risk is that when we look at the epidemiology, it is very common. Approximately 50% of individuals in the long-term care settings fall yearly. And about 60% of those who have a history of fall will fall and have subsequent falls. 34% of those 85 years old and older have fall injuries reported more commonly by women than by men. Simply because, we know the risk of osteoporosis, which is in both men and women, but in particular women who, have lost their estrogen over the years, become osteoporotic even faster, kind of a precipitous decline. And among community living older adults who sustain hip fractures, 25 to 75% of them don't ever recover back to pre-functional status. In a nursing home setting, the rates are about 70%. So it's a very big fear for the patient themselves. And complications resulting from falls are the leading cause of death from injury in adults older than 65 years of age. And it's the 5th leading cause of death in older adults. So, similar to, safety, which we look on the other side of the spectrum with young, our old patients really suffer tremendously after a fall. So falls for morbidity and mortality, you can go to next slide. Falls are the leading cause of injury, both fatal and non-fatal among adults. They're the really primary way in which we see injuries in seniors, and the significant morbidity and mortality, meaning increasing the risk of death at a sooner time, as well as morbidity, which includes, chronic pain, immobility, infections, hospitalizations we see associated with falls. So the importance of preventing falls is emphasized by a study that found that 80% of older women prefer death to a bad hip fracture that would result in nursing homes. So again, really strong implications on the families. So let's look at risk on the patients, So let's look at risk factors for falls. You can go to next slide, please. So if they have a past history of a fall, the risk of a recurrent fall is really, really high. Cognitive impairment and psychotropic drug use. So I just want to take a moment to really highlight cognitive impairment. As you know, most of us from on a clinical side and from a family side or caregiving side delay the diagnosis of dementia or cognitive impairment in our seniors. And that delayed diagnosis really puts the patient at risk. I would tell you that 30 to 50% of the falls that I see are at a time where I see there's a cognitive decline. And that cognitive decline really decreases the ability of the patient to be able to safely handle themselves while walking. So that is an important point to underscore. If you have a loved one who's not in a long-term care setting, or you're aging and you're concerned about, feeling unsteady, I would definitely say that a cognitive assessment is part of looking at somebody who's at risk for falls. As we know, arthritis can have a role because of limited range of motion in joints. Orthostatic hypotension, so that is blood pressure drops, which are normal even in young people when they stand, but in patients who are older, they have more profound lower drops in low blood pressure, which then cause falls because you become lightheaded during those periods. You've probably experienced orthostatic hypotension. If you're squatted or sitting down and you stand up quickly, you can feel that dizziness. And you feel kind of lightheaded and you're going to fall. So that's exactly what would happen to our seniors. And now you tack on medications, you tack on poor oral intake, you tack on dehydration, and you can see how.
Oh, I think she froze up again.
Lower extremity weakness is another one. And that's why we talk so much about the importance of physical therapy and occupational therapy. It has such a huge role in preventing falls. Your big, large muscles, the reflexes that you need are really obtained by the larger muscles. Balance issues. So patients who've had strokes, which has affected the cerebellum of the brain, or areas that affect balance, that can be a big risk factor, and we can target therapy on balance. So, we can do targeted physical therapy and occupational therapy on what we call vestibular rehab or balance rehab. And that's really focused on what we call neurogenic kind of focused rehab. People who've had a history of stroke and anemia, which is really easily treated as well through doing blood work, that can also be treated and can help prevent the risk of falls. So when we talk about sensory and postural loss, so I was just alluding to, you can go to next slide. I was just alluding to the fact that when you stand up from a seated position, you become dizzy because your blood pressure drops. So the blood does not get to the brain as quick as it should. And in seniors, this is even more profound. So a very easy educational tool you can give to your families or friends or loved ones who've sustained falls, or from a caretaking standpoint to our patients and residents, which I educate them all the time on, is they have to stand for 15 to 20 seconds before they take a step. There has to be a pause. And I educate my patients frequently on this because I've seen a profound improvement if they do take that pause. And then sensory systems, when we look at that, is we look at proprioception. So knowing where you are in space is a really important one. That's the reason why when residents transition to assisted livings, I really encourage physical therapy and occupational therapy very quickly. The reason why I do that is any change in the environment. So if your loved one's been living in their home for 50 years and now is moved to an assisted living setting or nursing home based setting or hospital based setting and is confined to a room where everything is in different position, they're going to be confused on where they kind of are in space because the surroundings have changed quite a bit. And then when we talk about vestibular systems, we talk about the ear. So as you know, Meniere's disease or vertigo or benign positional vertigo is easily treated with neurovestibular rehab, which we can focus that based on the way the physician or clinician orders the therapy to be focused on that. Visual impairments are really, really a very important thing to treat. Macular degeneration and glaucoma can be treated. And I really suggest cataract surgery for my patients. So, when we looking at the risk profile for a patient, should they undergo surgery? Are they able to undergo surgery? If there is a surgery that is minimally invasive, that can help with restoring vision. It is always strongly recommended. There's a lot of data to suggest that cataract surgery is markedly important in prevention of falls and risk of recurrent falls. And as we've talked about, and you've seen already in 3 or 4 of my slides, that a history of falls has a 15% risk. 15% of those who had a hip fracture will fall again in 5 years. So oftentimes, you know, what I see is recurrent hip fractures. So what we really want to do is target that patient and making sure we're optimizing everything we can. So one of the things that we can all do is look at medications. And this is something that I review all of the time when I meet a new patient and admit a new patient to my practice, is we look at medication reduction. So as a geriatric focused clinician, what we like to do is we like to look at what we call polypharmacy for a few different reasons. One is we want to avoid any unnecessary medications. One, because that medication itself may have an adverse effect and increase the risk of falls, but the medications together can potentiate the effects of each other. So they can make a medication that has a mild effect have more of a major effect, just simply because there's so many medications on board. So a lot of the drugs that we focus on are neuroleptics, so medications that treat seizures, benzodiazepines, medications that help with anxiety, antidepressants, and antipsychotics or mind-altering drugs. So they've done studies to look to see if the risk of fall is higher during initiation of the drug or with chronic use, and that data is still kind of a little questionable. So the reason why that's important is because if you have a loved one who has recurrent falls and has been on a medication for many years, you don't want to say that that medication was not the cause of the new fall. You know, chronic use of a medication, as your body changes, as the kidney function changes, as your health condition changes, that can have an effect on a drug that you've been on for years, and you may not be a candidate for that drug anymore. So it needs to be discussed with your primary care or your clinical provider, but it's definitely important to make sure that we're looking at new medications and old medications. You can go to the next slide. So footwear, this is one big question that I get asked a lot of the times, for diabetics, for my diabetics, where we can order diabetic shoes, or my older residents, and understanding, what is the best shoe for the resident. So footwear can be related to falls, especially if a patient's shoe kind of gets caught upon standing or taking the first step. We see that often, and sometimes the patients can kind of tell you that, or the staff member that was there may have noticed it. There was one small study that showed that actually thin, hard soles were associated with the best balance, although those shoes were perceived to be less comfortable than thick, soft, mild-soled shoes such as running shoes. So the kind of thick-based, flat kind of shoe that we're looking at, you can kind of reach out to like the local supplier for DME. We have a couple of different companies locally. There's a footwear place in West Springfield where you can go and actually be fitted appropriately for a shoe. So I really do believe that before you kind of make an initiation of which shoe, going to a specialized shoe specialist or to a podiatrist can really help to get the right shoe in place, because we often think that sneakers may be okay. They have laces, some of the soles are very thick, they don't fit appropriately, and they can actually increase the risk of falls in many patients. And they also did another study where they looked at greater heel height was associated with an increased risk of falls. So you really want to make sure that the soles are not extremely thick, unless you have obviously an imbalance in the height of the legs, and those were created specialized by a podiatrist, but you really want to try to go with a thinner soled shoe. There was data from Mobilize Boston study, which confirmed the protective effects of athletic shoes on falls and increased risk associated with going barefoot. So we definitely know that the risk of falls is very high going barefoot. So you definitely want to continue to encourage your loved one to get dressed every day, making sure they're wearing appropriate shoes every day. Can you go to the next slide, please? So environmental adjustments. So I get asked this question a lot about bed rails. And as you've known in the past, many nursing homes have placed bed rails. And we know that there's adverse effects associated with bed rails in the nursing home-based setting. So at this point, they really haven't done a study on bed rails and assisted livings. So I think the data still hasn't been studied. But it is clear 100% that there's use of bed rails has been associated with an increased risk of injury and death, and does not appear to decrease the risk of falls. So, many of the nursing homes have gotten rid of bed rails completely. In the hospital-based setting where the bed rails are higher and there's closer monitoring, those bed rails actually don't pose the same risk. So it depends on the environment where you are, but definitively from a nursing home standpoint, there's no increase, there's no evidence to suggest that bed rails work. Sometimes what we do is we get kind of an adaptive small rail that will help the patient pull themselves up from the bed in our assisted living setting. And I think the way that I would approach that, if you're the family or the nurse or the caregiver, is I would really work that out with occupational therapy and make sure occupational therapy, physical therapy are on board, and the patient can demonstrate that they can use it and it's effective. So the big question that we're going to look at, you can go to the next slide, is how do we really prevent the risk of falls? So I've already kind of alluded to medications as a really easy way to look. So we want to look in particular on drugs that we've kind of already talked about: psychotropic medications, benzodiazepines, antidepressants. Those are easy ones to look at. The other ones that I didn't list on here would be medications for the treatment of overactive bladder. Those medications are listed on it's called a Beers criteria, and you can look that up. That's widely available. You can type it into Google. There's a list of medications that aren't suggested in patients over 65. And medications that treat overactive bladder really can dry the patient out. That's kind of what the thought process with the medication is to dry the patient out. They can increase dizziness, they can increase risk of falls and confusion. They're called anticholinergics. So they work really strongly on the brain and on the genitourinary tract, which can really be a big risk factor for falls. So if I have a patient who's essentially incontinent or has dealt with their incontinence and it's more related to, pelvic insufficiency, older age, women who've had children, I really suggest getting off of the medication for overactive bladder. So that's a really easy one, and I do that quite often. We as the healthcare professionals used to classify falls as either mechanical or syncopal, trying to determine exactly what the cause is. And actually, we've moved out of saying that this is a mechanical fall. The meaning of a mechanical fall means that there was nothing really contributing. It just happened because I had weakness, or I fell because I lost my balance. So we really try to step away from that. Every time your loved one has a fall, or your patients have a fall, what you really want to try to determine is the cause of the fall. Falls don't happen on their own. Falls usually happen because there's a precipitating effect. I would tell you, precipitating event, excuse me. I would tell you that 60 to 70% of my patients who have falls, I can usually nail it down to either an infection, medication adverse effect, abnormality within the blood work. So when there is a fall, you really want to do some surveillance and detective work to determine what the cause of the fall is. And that's the importance of documentation of the circumstances around the falls, because it'll really help us determine what the cause could have been and prevent further falls. So for patients who are 65 years and older, and 50% of those who live in a long-term care setting will fall each year. I mean, I think that's a generous, I think that's not even as generous as it is. I would tell you that 70% of my patients fall over the year at one point. So the key is getting physical therapy started as soon as possible. We know that when we look at the large muscle fibers, so quadriceps, hamstring strengths, our upper arm strengths, our musculature and our upper extremities, all of those things, all of the muscles being as strong as they can be, and as
Every once in a while she freezes up, right? So everybody else can hear,
Oh.
you could hear me. Oh, Dr. May. Oh,
Can
there
you
you
hear
are.
me?
Every
Okay.
once in a while. Yeah, every once in a while you'll freeze up.
Okay. So, the importance of physical therapy, I was saying, was that what happens is when before a person has a fall, they kind of know they're going to fall, whether they lose balance, unless it's like a cardiac reason for fall and it's just an immediate loss of consciousness, that's different. But let's say a patient was walking to the bathroom or became a little dizzy or lightheaded, what you want is your reflexes to be in place right away. And the only way that you're going to have a strong response with your reflexes is if your muscles are conditioned. So the importance of getting physical therapy and doing some small amount of weight strength training is really important. The other thing that we kind of discussed and I alluded to before is we talked about vision. So I really strongly recommend cataract surgery, macular degeneration, and glaucoma treatment, assessing.
Oh, there she goes again.
Assessment should be looked at. So, oftentimes we have sometimes recurrent falls and there's a cardiac issue going on. That's a little more complicated for the families or nursing to kind of allude to, but that's definitely something that should be discussed with the physician. Now we've moved into, because Holter monitors or external monitors to see what's going on with the heart function is hard for a patient who's older to be able to manage the device. In some cases, I really do think it's indicated that you can have an implantable device placed, which can monitor your cardiac status at all times. And if your heart rate is going up or you're having some irregularities, if that is treated, it can really decrease the risk of strokes and recurrent falls. So that really needs to be assessed. And there is carotid sensitivity. So the large arteries in the neck may be sensitive during bowel movements or if pressure is placed on them. And some men, when they wear a collared shirt that is very tight fitting to the neck, it actually can cause some carotid sensitivity and drop the heart rate, which can increase the risk of falls. So let's go into some fall risk interventions that you would want to talk to the doctor about and kind of determine if this would be an appropriate treatment for your loved one. So if you can go to fall risk interventions, perfect. So osteoporosis screening. So, it's the idea of going through a DEXA scan or having extensive osteoporosis testing. I kind of go back and forth on it depending on the level of patient that I'm handling. So I think if somebody's bedbound or really limited in range of motion, I don't think there's a lot of data to suggest that osteoporosis screening is important. But for our patients who are walking and who are still fairly mobile and are transferring, we really should definitely look to consider treatment with bisphosphonates for patients who have a history of osteoporosis to prevent subsequent fractures. So if they've had a fracture and it's noted during the time that they fractured that
Dr. May, I'm not sure if you could hear us.
Can you hear me?
Oh, there we go. Okay. There was just another skip. That's all right.
Okay.
We've already said that there may be technical difficulties, so you're good. I just don't want anybody to miss anything.
Okay. And so we just talked about osteoporosis screening, and the next one is assisted devices. So I just want to make a point about assisted devices. The data is still out there on if walkers or canes really help prevent falls. I think the key of when they do their recommended job and goal of having assisted devices is when patients know how to use them and they're compliant with using them. So we really want to make sure that the walker is measured appropriately, the size, and for the height of the patient. As the patient's height changes, that may need to be adjusted. We also want to make sure that the walkers, canes are constantly being looked at by physical therapy and being kept up to date from an equipment standpoint. I want to just touch on the time on the floor.
Oh. Yeah, Dr. May. Oh, there we go.
Are you back? Or am I back?
You're back. You're back.
Okay. So for the alarm systems, what I was alluding to is that 99% of those who could not get up at some time and had an alarm system in place, the alarm system was not used. So if you have a person who's cognitively impaired and you have a assessment of their cognitive status and their ability to really accurately use the alarm systems. When they did a study of over 1,100 individuals over 72, they found that 47% of those who experienced falls were unable to get up for at least 1 hour. We know that prolonged periods of time on the floor are associated with serious injury, and they can be associated with muscle breakdown, hospital admission, and almost irreversible kidney damage. So you really want to make sure that if you are using an alarm system, that the patient accurately can use it and that there's a second check in place, because if they do fall and can't get up, that is going to be a really big risk factor for advanced decline in morbidity and mortality. Anticoagulation. So I get this question a lot in terms of Coumadin and if patients should remain on Coumadin if they have recurrent falls. And at this point, the new studies have suggested that if a patient is still cognitively intact and is doing well on Coumadin and has had a fall, that usually the cause of death is not going to be from major bleeding associated with anticoagulation. So there's a little bit of a change in the data there. So when I graduated almost 13 years ago, if there was a high risk of falls, we would immediately take a patient off Coumadin. What we're seeing now is if we're taking patients off Coumadin too quickly, they're having recurrent strokes that are undiagnosed that then cause falls. So you really don't want to just make a impulsive decision of saying, I want to take my loved one off of the Coumadin or the Xarelto or the Eliquis, because if they have cardiac issues that are significant, these medications will keep them cognitively stronger, physically stronger, and prevent strokes, which will ultimately improve quality of life. So I really think it's a weighted discussion with your provider before you impulsively decide to just stop anticoagulants. That's what the newest study shows. So we're on to our last slide, which are summary and recommendations. So at this point, the key,
Nope. Where'd she go? Luckily, she comes right back. Oh, there we go. Oh,
okay. So we want to kind of do a multidisciplinary risk factor screening program. So we want an exercise program in place. We would like a hazard assessment in place. So occupational therapy in place, physical therapy in place, and a fall risk screening yearly, which we recommend to be done by your doctor. You want to do a medication review, and vitamin D has still been shown to decrease the risk of falls, and we really still strongly recommend the use of vitamin D and to optimize vitamin D levels. So the data is still very strong on supplemental dose of vitamin D. And hip protectors were discussed at some point, which is a device you can place onto a hip to see if, you have a loved one that may fall, would have some type of protective device to prevent that. And the data on hip protectors are not very strong. In a small portion of patients who are followed by their orthopedic or specialized musculoskeletal team, there may be some data to suggest that hip protectors are good. The key is that most patients don't wear hip protectors, so they're non-compliant or they wear them incorrectly, which decreases their ability to serve the purpose of what.
well, we're almost through.
Questions?
Oh, there we go.
Yeah, we're pretty much done. So I'd like to open it up to questions on families or colleagues or anybody in the community that's here who would like to get some more information.
So is there anyone, I just stopped sharing. Let me just check. I don't think I have anything in the chat. Does anybody on the call have any questions for Dr. May? Well, Dr. May, I will ask one. I know we were talking a little bit about assisted livings and, you know, of course, I know Christina knows this, where people will ask, you know, can I get a bar on my mom's bed or my dad's bed? Now you were saying that there's some, what is it called, a U bar? I mean, some of them are acceptable in an assisted living setting because some of them are not, correct?
Right. Yeah. I think if the key is that the smaller ones are probably safer because they are less of a risk. And they're not a restrictive device, because you don't want to restrict a patient because then they can get trapped or they can try to come out of it and fall doing that. So the key with that is your occupational therapy and physical therapy. The patient and the nurse all kind of need to interdisciplinary do an approach to look at the patient being able to use the device and seeing if it's an effective device. So I think the data on it is questionable. Definitively in nursing homes, we do not recommend bed rails.
Okay. And you were saying that barefoot increases your risk of fall?
Yes.
And why would that, here I would think, I see some people with those, you know, the bigger shoes with the bigger soles, and it's almost like sometimes they trip over the soles.
Yeah,
Not that I think barefoot is the best way to go, but it's almost like I didn't realize that that would be an increase in falls.
Well, a lot of our patients, you know, have poor blood supply to their feet, and they don't know where.
Oh, don't know where something.
Of kind of not knowing where you are in space and in place. The other thing is patients also have poor sensation in their feet, so they don't know really to what level they're stepping, and the slipping risk, right? Because if they dropped water and they're barefoot, their risk of slipping is much higher as well.
That makes sense.
Yeah.
That makes sense. And as far as like medical, you know, medicine interactions, I mean, how, if somebody doesn't have you as a primary care physician, I mean, do they just go to their visit? What if they're going to like multiple doctors? You know, how do they do that? Can they call you? I mean, is there, you know, can you still help them with that if you're not primary care, or how does that work?
Well, I think what we can do is we can create a list of questionable medications that Beers criteria. I can probably email you that after we complete the meeting, which will have a list of kind of black box warning medications. So that way the family members can do that. Contacting me won't help because I don't have authority to discontinue the medication. I think that the key is that they keep an updated list of everybody's medications. They need a full, updated, accurate medication list, which is why a lot of the times I fill most of the medications for my patients, because if I don't know what else they're on and I'm not prescribing it, sometimes it's really difficult to keep it that accurate. So it's really up to the person who's managing and coordinating the care of the patient to keep an accurate, updated med list with all medications. And that really should be done by the primary care physician. Most of the specialists will not really get involved. I would tell you, I have a lot of requested visits for medication review for polypharmacy. So you could actually create a visit with your doctor and say, I'm concerned because mom is taking a lot of medications. Please make sure you include over-the-counter medications. Those should also go on the med list, because many over-the-counter medications, such as Benadryl, certain cough medicines, all can actually have pretty profound effects on the patient that the doctor may not know, as well as supplements.
Okay, so it's just a matter if we've got either clients or loved ones that it looks like they're on a number of scripts, just to maybe reach out to the primary care with a list and say, you know, hey, what about a pharmacist? Would a pharmacist be able to help with that?
Pharmacists are good. I mean, they'll be able to pull up the interaction. I think more importantly, the doctor kind of needs to look and say, you know, what is really helping her? Because the pharmacist will just look and say, yes, this interacts with this, but I'm not really sure if she really needs it. So
Right.
You really want to look at a medication and say, is it helping the quality of life? Is it impactful?
Right.
Yeah.
Yeah, I think that gets scary because we've seen some people on a lot of different medicines where, you know, you don't know if they're all necessary, and you don't know if one doctor, you hope that everybody's talking to one another, but that's not always a guarantee. So it's almost like somebody needs to be that advocate to say,
Correct.
you know, we need to kind of put all this on one table and look at it and say, you
Right.
know, what can we do away with? And the minimal amount of medication, I think the better.
Exactly. And that's really where a strong primary care doctor will be the gatekeeper for that.
Right.
Mary Ann, I'm sorry to interrupt, but Dr. May, that is something that I'm sorry, Jody with MedMinder Pharmacy.
Yeah.
Daily, we work with the PCP, the specialists, and the multiple pharmacies. So we'll gather all of that information and do a complete reconciliation. And there's an extensive process, which does take time. But it's amazing how many individuals are taking medications that another physician says is an allergy, or medications that are conflicting.
Oh, I
So
know.
that's one of the beneficial things that we find, even if a member, because there's no contract with us, if we of course want them to take advantage of all the services that we provide. But one of the greatest things is meeting a family and realizing an individual hasn't been to a physician in over 2 years. So just kind of getting that ball rolling and connecting.
Yes.
That is important.
Yeah. And as the family, the best thing you can do, or the caretaker, the nurse, is keep good record keeping, because when you go to the doctor, you want to be able to have the most efficient visit. And if you have everything laid out and ready and prepared, then you'll have a very effective visit with an immediate intervention.
Yeah, that's great. Jody, thank you. Now, does somebody have to be working with you in order to get that service, obviously?
Yeah, I mean, we really can't consult for other physicians, because when you look at the medications, you need to look at your patient, you need to look at the medications, and you need to look at their medical history.
Sure.
And on a one snapshot, I will have a very limited history. For example, I have some of my patients that are on high risk medications, but they're on them for reasons because we've tried so many different things. And this high risk medication actually turned out to be safe or effective, most effective. So without that medical history, it's really hard to go in as a one-time snapshot, because there's a lot of things that might not fully be apparent.
Right. All right. We do have a couple of questions. We've got this. Donna Fine wants to know, what is the cognitive assessment and where is it taken? Oh, we lost her for a minute. There we go.
Go ahead.
Did you hear that?
No, I didn't. Go ahead.
Okay. What is the cognitive assessment and where is it taken? Oh, darn it. Looks like we lost her again. Oh, poor Dr. May. Testing one. Oh, there we go.
Okay. There's something called a mini mental status exam, which can be done at a doctor's office. It's based out of a 30-point. There's another cognitive assessment called a MOCA. And then there's a more thorough neurocognitive assessment, which can be done by a neurocognitive psychologist. So what you really want to do is know if your loved one is starting to have signs of cognitive impairment early on, because then that will put them in a risk for falls and hopefully prevention before that sentinel fall happens. So when you're conversational with a patient or conversational with your loved one, frequently it's very hard to see their cognitive decline. What you need to do is you need to challenge them. When you challenge them is when you'll start to see their cognitive impairments. So doing math with them, seeing how they do with reading and reading comprehension, seeing if they can do 4 or 5 tasks at once, seeing if they can do serial 7 count backs, seeing how they do with writing a sentence, seeing how they do with sitting up from a seated position, how long it takes them to get to the table. So these are, kind of pressured systems. When we're dealing with our loved ones or our parents, our friends, our sisters, aunts, uncles, we don't really challenge each other on that level. So it's very hard to see if there's a cognitive decline. And really the only way to do that is through the thorough testing. And that can be done at the primary care doctor's office.
Okay, perfect. So Donna, I hope that answered that question. I know you have another one. So start with your primary care, and then Dr. May, she also asked, what do you advise for osteoporosis after a reclassed infusion?
Well, the reclassed infusion is being used. What do I suggest after that?
Yeah, what do you advise for osteoporosis after the reclassed infusion?
Well, you could, I mean, it depends. So if the patient is no longer getting the reclass infusions, is the patient now off of it?
Donna, I don't know if you want to unmute yourself and you could answer that for Dr. May. Donna, are you there? I still see her on the screen. She's just muted. She had typed it into the chat. So I'm not exactly sure the details of it.
Okay, I mean.
Here we go. She just unmuted. Hi,
Okay.
Donna.
Hi, how are you?
Good. Maybe.
Yeah, I was diagnosed with osteoporosis myself.
Mhm.
And I did have a reclassed infusion, but I had an allergic reaction to it.
Right.
And
Okay.
so I'm at the point now where I don't know if I need other medicines or what my next step might be.
Yeah.
Oh, Donna, I'm not sure if you see it. She just froze up for a second. Give it a minute. She usually comes right back.
Processes,
Right,
and if
no
there's
problem.
Oh, there
And
we
if
go.
there-
All right. All right, Dr. May, you're back.
Okay. So the question is you want to know like how severe your osteoporosis is, and you want to think about if smoking, how much you do in terms of exercise, strength training. So you want to kind of look at your risk if you don't treat, right? And
Correct.
then if you feel that that risk is high and you have family members who suffered from osteoporosis or spontaneous fractures, or you've had that, or you were diagnosed with severe osteoporosis and have risk factors, then I would suggest trying possibly an oral bisphosphonate. You know, there's so many different treatments now. So if you failed the IV, I wouldn't completely close the door on other modalities. Obviously, I would be nervous about another IV formulation, but you could consider oral, or you optimize your vitamin D, or consider having another screen in a year and then seeing where you are.
Okay, sounds great. I do take vitamin D every day, by the way, for several years.
Excellent. And I really suggest you to optimize that because that has a big role.
Wonderful.
Yeah.
Okay, thank you so much.
Yes, my pleasure.
Great. Does anybody else have any other questions? Norma, I just saw your, where are you? Norma, I just saw yours. Christina, I don't know if you had seen the chat. She needed to know the name of the bird, but I said Tweety is a cockatiel. So yes, literally, I'm going to tell you a funny story. This bird walked into the building, right? So I'm AOC. I've got a call from the front desk saying, there's a bird in the building. And I'm like, all right, well, you know, you got to call maintenance on call. They could get it out for you. And it's like, no. It's like a pet bird. And I'm like, what do you mean a pet bird? And they're like, no, it's like one of those pretty birds, like with a lot of colorful feathers. And I'm like, all right. I said, so, you know, I'm calling the nursing home. Did anybody lose a bird? I'm calling, you know, Wernick Adult Day. Did they lose a bird? Calling the police station. I don't know, right? It's like a lost puppy. Calling the police station. Did you lose, you know, did anybody report a lost bird? Nobody said anything. I'm like, listen, can you go out and, you know, can you grab somebody to get a small little cage? She said, sure. So we had it in a small little cage. We didn't know. Nobody had a bird. And then one of the residents' families came in and said, yeah, that's too small for that bird. And it's like, well, we don't even know if it's ours or if somebody's going to come get it. This is just like a travel for now. And they're like, no. So we went out and we bought this big cage that you just saw in the video for the bird. And then it's like, all right, I guess the bird is ours, right? They probably, you know, somebody left it on the front steps thinking that, you know, the seniors would take care of the bird. And everybody voted on a name. And I know it's not that creative, but it's Tweety. And they love the bird and the bird loves them. I love the bird. Whenever I go over there, I taught the bird how to whistle, like, like, I'm not gonna be able to do it on screen, right? But, like, he still can't do it. Literally, I will go and do it every single time I'm there. If I'm there long enough and if I spend enough time there, he'll whistle back. That's worth it right there. But yeah, Norma, that's the bird story. But yes, he has a name and he's a cockatiel and he is very well loved by the residents there. All right, so we've got, let's see. Well, Susan had to step off. We answered Norma's question. Let's see, we do have another one from Lisa. I work with a non-medical home care agency. Do you find yourself referring to caregivers to help someone rehabbing to encourage PT exercises, shadow for safety, and increasing cognitive engagement? Also, how does the medical community encourage prevention and strength training at a younger age?
So the question is our encouragement of physical therapy?
Lisa, if you want to unmute, you're right there, so you could ask her.
No, the question is, how can prevention really happen before someone gets to the stage that their muscles are weak, they're 70s, 80s, and now you have extra work to do.
That's such a great question. It is such a great question. Advocacy, that's really what I would say. I think it's education and advocacy, both. So, it all starts with our communities and it all starts with our circle of support. And, my grandfather, for example, became kind of wheelchair bound, bed bound. And looking back, at it, I kind of said, at a time when an intervention could have happened, he was quite resistant to wanting to do that. But I feel that if more education had been provided to him by the healthcare team, by his children, by me, by those around him, I believe that he would have been slightly more compliant and he would have been challenged, right? So, and I think a lot of that is motivation, helping with making sure he's motivated and having somebody really advocate and have him or her on a schedule. So it's a layered question. It's a community support. It requires multiple people to be involved and multiple people to create a care plan. Kind of what's done as a VNA, with the VNAs, with the physical therapy, they create a care plan. Mm-hmm. So it almost needs like a multidisciplinary, all-inclusive approach. Because there's definitely a mental, emotional, and physical components that all go into your ability to remain physically active, cognitively strong, emotionally well.
Well, the first part of the question was being from a non-medical agency. Certainly when someone's not doing well, the shadowing, the assistance, all of that is great. But there's someone who used to work with us who's in her 70s, very, very fit. And she actually teaches a course. It's free. It's through some of the senior centers.
That was the next thing I was going to say is the senior centers, I think, are a great resource. One, because they enhance socialization and they make people aware of services that they may not know about. Social work and Springfield Greater Senior Services may also have some great resources.
And maybe it's just all of us going to our own senior centers and saying, hey, do you have this program? Because I've seen the people in the classes and they're 70s and 80 and they're lifting weights and
thriving, right?
Prevention.
Right.
Ever.
Right.
And then one more thing, because I've received phone calls and people will say, well, who do I go to as far as getting a cognitive screening for my parent? And, it's not like I have this list, but I guess starting with the primary care, right? I mean,
that's really, Yeah, that's really the way. And if the primary care can't really, you're not getting anywhere with the primary care, then you could ask to see a neurologist because they're very good at cognitive screenings. And the other one is a neurocognitive neuropsychologist. So we have a couple in the area. Dr. Kliansky does really extensive testing, almost 3 to 4 hours, but that will definitively diagnose the cognitive impairment and really characterize the exact type of dementia, if there is one.
Okay, I guess you could start with him. Was there another name other than Kliansky or anything that comes to your mind?
There's another group out of Bay State.
Okay, okay.
So it's the Bay State Neuropsych.
Okay, thanks. Very
Yeah.
much.
Does Constance Carpenter Bixler still do those?
I'm not sure. I haven't seen that name recently.
I know she used to, but that's another name you could look at, Lisa.
Yeah, I remember that name.
Yeah, she was great when she was doing them, if she still does them.
It's a lot.
Yeah.
Yeah, it's labor intensive.
Can I ask one more question, Marianne?
Of course.
Okay, so Dr. AWKAL, have you seen in the hospitals, because of the COVID testing being mandated, have you seen decrease staff, nursing staff, CNA staff? Have you seen that affecting care? And I know it's not a fall related question, but I'm asking.
Well, I think as a nation and as a community, we're all really struggling with COVID because I think everybody hoped that it was just going to last and go away, or, we were going to have better control of it. So I think as a nation and the world is really, really struggling. A pandemic is not easy. I believe we're starting to get in what's called the endemic phase of it, which means that it's here. It's become a common viral illness. In terms of staffing, I think healthcare has struggled tremendously with the COVID pandemic, simply because, we are wearing PPE all day. We're on very high stress alerts when we're at work. Everybody's testing, you have to contact trace. There's just so much to do. So I think our healthcare system is strained. It was strained prior to COVID. It's more strained now. But I think that there needs to be kind of a recharge and a reset for a lot of communities. And I think this created, some changes within institutions. So that goes from the larger level. We see it on the federal level with the CDC and everything. We've seen so many changes there. We've seen it from, pharmacies now, which are more stressed. Remember now, the pharmacists, are administering COVID vaccines. They're having to fill meds and do all this. So the pharmacy system is stressed. Our leadership is exhausted because everybody's working 24/7. And then that trickles down to, physicians, doctors, nurses, aides, all of us who are fatigued by being in this crisis. I think, what the importance, we just had a what we call grand rounds at Bay State, and we talked a lot about physician burnout. And I think we need to address burnout in all levels. I think people need to have outlets during the pandemic. And I think, self-help will be of the most importance. There's also a huge economic effect on this, on large corporations and on service professionals who can't get their kids to school and they can't work. And the cost of care is tremendous. So I definitely am seeing stress on the hospital level. I'm seeing staffing issues in every capacity. We have major staffing issues. So all we can do is do our part and stay positive and try to create a positive environment, avoiding aggressive behaviors and negative behaviors due to, feelings of the stress of the pandemic. and supporting our communities. We have to just, we can't change our lives in every way. We have to change our lives to protect us from a health standpoint, but we have to maintain our role in society.
Thank you. Well said.
Yeah.
Well, Dr. AWKAL, I'm really appreciative of you being here, and obviously this was important for us to hear and to really, I'm glad that you were able to answer the questions that folks have. Am I now, the slides that you sent over, is that something that I could email out?
Sure,
So they
absolutely.
can have the information? And I just saw Phyllis just got on the call, so she kind of missed your presentation, but if that way there, I could actually send out the slides.
Yeah.
That would be great.
Yeah. And thank you, Marianne and Ruth's House, for being such supporters of our practice, my practice, and all of our PAs and NPs, and amazing. I have such an amazing team, and I work with such amazing colleagues in the geriatric world that I'm really appreciative to you and to Ruth's House for the continued support of the residents and creating support from healthcare leaders and professionals.
Of course, we're very excited and thrilled to have you on board. So yeah,
Thanks.
Thank you.
We really appreciate your support.
No problem. No problem. And as long as there's no more questions, I'm going to let Dr. AWKAL go while I pick a winner for the kitchen gift card. Any more questions?
Good luck.
Oh, no. All right. So Dr. AWKAL, you're free to stay or you're free to go.
Okay. All right. I have to get going, but thank you very much. Thanks.
All right.
Thanks.
Yeah.
Stay healthy and well and positive. Thanks.
Perfect. Thank you.
Okay.
You do the same. All right. And hang on, guys. Let me just grab this. All right. So we have, it's sticky. Oh, Eric. That's you. All right. So I have got a $25 gift card to the kitchen.
Thank
So
you.
I don't know if you want to, we could plan on meeting up and you could buy me ice cream. No, just
That
kidding.
sounds like a plan. Yeah, we'll figure
No,
it out.
normally what I do is we could meet at Starbucks. I'll buy you coffee and I'll give you your gift certificate.
That's awesome. Hey, I will be in touch.
That's perfect. Excellent. Well, congratulations.
Appreciate it.
Nice.
I know your kids will like that soft serve.
Yeah, I know that's not not
Yeah.
going to me anyways.
You're not gonna get any of it. Yeah.
Yeah, that's fine.
That's too funny.
Sure.
Now, does anybody else have any questions? Phyllis, I know that you just got on. I feel bad that you missed the presentation, but I will be sure. I do have your email address. I will send you the slides. Do you have any questions that I could possibly answer?
No, you know,
Okay.
I was actually in the doctor's office, so that's why I was late, but I was listening on the phone.
Oh, perfect. Okay, perfect. All right, that's great. I'll still send out the slides to everybody. I've got everybody's email that registered. I've got everybody, so this is perfect. Thank you all for coming. I'm really appreciative. And if you have any questions on Ruth's House, you've got Christina's information. And then if you've got any questions on a campus altogether, you could reach out to me. But again, thank you. And then don't forget that next month, I didn't put up that slide, but I'll just tell you, Wednesday, October 20th is our next Lunch and Learn at 12 noon, of course. And we're going to have Katie Krupka from Tucked In Elder Care discussing the benefits of working with a geriatric care manager. So that actually should be very good as well. So that's October 20th. So mark your calendars. And you'll be able to hear from Katie Krupka, who's also a senior advisor. And then she just actually started working more full-time with Tucked In Elder Care. So we'll be able to learn a little bit about geriatric care management. Okay.
Thanks,
Thank you. It was really good to see everybody. I hope everybody has a great afternoon and may be able to get outside while it's still sunny before the rain comes back.